This video is sort of the rest of the diseases you need to know about for the test that don't fit into a major framework and aren't big enough to have their own video. So we're just going to go through 3 different diseases: scleroderma, which you have to know a lot about; Sjogren's, which is pretty simple; and then we lump all the myositis together because their presentation and workup is very similar. So we're going to start with the hardest one, which is scleroderma. And scleroderma is essentially collagen deposition. We don't really understand a lot about it, but we know what it does. Right? And basically what's going to happen is that collagen is going to get in everywhere, and collagen doesn't really move, so it makes everything it gets into stiff. There's going to be 2 presentations. What's called limited cutaneous systemic sclerosis, which I'm going to call CREST. They are, in fact, different diseases, CREST and limited cutaneous, but I want you to learn it as the same disease because there's very little difference between the 2. And it stands for CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. All right, let's translate that. GI bleeds, iron deficiency anemia. Your fingers are going to be all tense, and you're going to lose any signs of wrinkles or knuckles. They're not going to be able to expand because the skin has been replaced by smooth muscle. Unrelenting GERD. When your fingers get cold, they're going to vasoconstrict, get white, then purple, and hurt, and they will dilate again when you expose them to warmth, and your vessels don't work right, generally in the form of high blood pressure. The other form, called diffuse cutaneous systemic sclerosis, which I'm just going to call scleroderma, is limited cutaneous plus. And it's plus visceral involvement, and that's the major difference. Diffuse cutaneous systemic sclerosis can involve the lungs, the heart, and the kidney. And what it does to the lung, heart, and kidney is cause interstitial lung disease, which we now call diffuse parenchymal lung disease. In the heart, it causes constrictive pericarditis. In the kidneys, it causes a scleroderma renal crisis. Okay, let's do this again in pictographic form. I'm drawing with a really long neck on purpose. In the limited cutaneous form, the CREST syndrome, you're going to see the hands and the face get really tight. There's not going to be any wrinkles at all, even though they're a bit older, and that's because they've been replaced with collagen. The only visceral involvement of CREST is going to be the esophagus, which leads to the unrelenting GERD. In diffuse cutaneous, you're going to have the same things that are listed in green, but also are going to have interstitial lung disease, DPLD, constrictive pericarditis, and renal crisis. Here's the problem. Treatment doesn't exist. I know we haven't talked about diagnosis yet, but what I want you to feel is that when you make the diagnosis of scleroderma, you're only going to be able to control the symptoms rather than treat the disease. So let's talk about how you can manage some of the things that occur in the CREST syndrome. For telangiectasias, you're not going to be able to do very much. For sclerodactyly, you can use penicillamine. For esophageal dysmotility with unrelenting GERD, give them a PPI. For Raynaud's, you can use calcium channel blockers. And the same thing is true of the calcinosis. So treat them symptomatically. For scleroderma renal crisis, you will use an ACE inhibitor. Stop and pause and talk about this one for a little bit because I really wanted to drill this in. This is an inflammatory disorder, right? We're in rheumatology. So your instinct would be give steroids. If there's a problem with the kidney and it's an inflammatory disorder, give steroids. Most of the time that would be right. In scleroderma, giving steroids may actually precipitate a renal crisis. So you do not give steroids in scleroderma renal crisis. You give an ACE inhibitor, and that will be counterintuitive. It will look like an acute kidney injury, and you know to hold ACE inhibitors in the setting of acute kidney injury. Except in the case of scleroderma. If the person has scleroderma and their creatinine is going up, give them an ACE inhibitor, avoid steroids. All right, what else do you need to know about these diseases? Well, there's going to be a serology that goes along with each one. The CREST syndrome is going to go along with anti-centromere. There's a C in centromere, there's a C in CREST. That's how I remember anti-centromere for the CREST syndrome. And CREST can cause pulmonary artery hypertension. It just causes pulmonary artery hypertension without any damage to the lungs. Versus diffuse cutaneous, which is going to be associated with anti-SCL70, SCL for scleroderma, also called topoisomerase. And because it causes diffuse parenchymal lung disease, it can lead to pulmonary artery hypertension. This is important. Diffuse cutaneous systemic sclerosis causes interstitial lung disease that leads to hypoxemia, that shows lung changes on x-rays, and then causes pulmonary artery hypertension. CREST syndrome can cause pulmonary artery hypertension with normal-looking lungs without hypoxemia. And the last thing you need to be able to do is compare this disease to nephrogenic systemic sclerosis. Nephrogenic systemic sclerosis causes the same physical appearance, the sclerodactyly, the loss of wrinkles on the face, but occurs after receiving gadolinium in someone with chronic kidney disease. If there's no mention of an MRI and there's no mention of CKD, then don't have to worry about this at all. If you see the word gadolinium in a question, look for nephrogenic systemic sclerosis, because why else would they tell you they got gadolinium? When you see a question with sclerodactyly and the loss of skin folds and the loss of wrinkles, look for the MRI in chronic kidney disease, pick nephrogenic systemic sclerosis. Otherwise, choose scleroderma. There's a lot to know about scleroderma. There's a lot less to know about Sjogren's. Sjogren's is caused by lymphoplasmacytic infiltration of the exocrine glands. A lot of words, which means that if you take a biopsy, that's what you're going to see. What would you biopsy? The parotid gland. What are you looking for? There's three things that make up Sjogren's syndrome. Dry eyes, called keratoconjunctivitis sicca. Say dry eyes. Dry mouth, xerostomia. Say dry mouth. And parotid swelling. Keratoconjunctivitis sicca, dry eyes, xerostomia, dry mouth, parotid swelling. It is possible for there to be an extraglandular form, which is associated with arthritis. I don't want you to learn that. Learn this: dry eyes, dry mouth, parotid swelling, Sjogren's syndrome. The diagnosis begins first with a screening test. ANA and rheumatoid factor are normally positive. Then the better antibodies to get are Rho and La. You should associate Rho, La, Sjogren's. And you can do the Schirmer test. The Schirmer test is where you see if can they make their own tears. And there's really nothing wrong with having this disorder. All you need to do is give them artificial tears and artificial saliva. It's an annoying disease to have because you have dry mouth and dry eyes, and you have to constantly apply drops and eat your food with artificial saliva. But these people live a normal lifespan and generally don't have any other problems. And the only thing you might consider is this initial presentation of another rheumatologic condition? Because sometimes secondary Sjogren's syndrome is associated with lupus or rheumatoid arthritis. So it's worth screening them by asking them the questions to look for lupus and rheumatoid arthritis. But most of the time, you're going to be diagnosing primary Sjogren's, dry eyes, dry mouth, parotid swelling, no arthritis, and simply giving them what they don't have, the artificial tears and the artificial saliva. And the next disease is actually 3 diseases in one. And I lump all the myositis together, the inflammatory myopathies, because they just, at this level, are essentially the same disease. They're different, and there's little details in each one, but they're not worth committing to memory because they're going to present the same way and you're going to work them up the same way. Idiopathic inflammatory myopathies, what I call the myositis. There are 3. Inclusion body myositis, polymyositis, and dermatomyositis. Dermatomyositis is complex deposition disease. Inclusion body myositis and polymyositis are T-cell disease. And now we're lumping them all together because they present very similarly. What I want you to hear is that even though inclusion body and polymyositis have a similar pathology, it is inclusion body myositis which is the different one. Polymyositis and dermatomyositis essentially are the same disease, literally, in the way of presentation and management. Inclusion body myositis sort of sits on the fringe. You learn them, all the same disease. So how are they going to present? What you're looking for is a proximal muscle weakness. That is, difficulty rising from a chair or getting things from overhead. It will be painless and subacute. It can be associated with a malignancy. And so whenever you diagnose this, any of the 3, you should do age-appropriate cancer screening. These generally occur in the older population, 40 to 60, 50 to 70 range. What you're looking for are going to be the skin manifestations and muscle weakness. Remember, you've got proximal muscle weakness, which is why you have trouble getting out of the chair or going up and down stairs or reaching overhead. The distal muscles are usually okay. Inclusion body myositis can actually have distal disease, but I want you to remember this is mostly proximal. If you see the heliotrope rash, that purple discoloration of the eyes, it's almost pathognomonic, and it is for your test. If you see instead the Gronton's papules, which are scaly regions that are symmetrical, usually on large joints, pathognomonic, it is the disease. And you might also see the Scholl sign, which is a photosensitive rash. So any area that is exposed to sunlight gets a rash. Heliotrope rash, Scholl sign, Gronton's papules, plus proximal muscle weakness, think idiopathic inflammatory myopathy. The diagnosis goes something like this. Because you've got proximal muscle weakness, you want to know is there muscle damage. So first you're going to get a CK. And the CK will be elevated. Then you want to know is the problem the muscle itself or is it a neuropathy? You've pretty much decided that with the CK level, but regardless of the elevation of the CK level, you should get an EMG. An EMG will say, yes, indeed, it is the muscle and not a neuropathy. There's also some characteristics of the EMG that tell you, yes, indeed, this is an inflammatory myopathy. But I don't want you to learn those words. Just know the EMG is the test to get. The best test is a biopsy. And the biopsy will differentiate dermatopoly and inclusion body. There are antibodies that are associated with this, and there's like a lot of them that you could memorize, but the ones you should commit to memory are anti-Me and anti-Jo. The problem with this disease is that there's a lot of antibodies that are specific, but their being positive or negative doesn't really help because there's a lot of them. They're only positive in a very few cases. So the antibodies are not the way to go with the inflammatory idiopathic myopathies. It's going to be the CK level EMG and a biopsy that helps you the most. And the treatment is going to be steroids. Steroids work really well for poly and dermatomyositis and not so much for inclusion body. Again, I want you to run them all as the same disease: proximal muscle weakness, subacute, Groton's papules, heliotrope rash, then get a CK EMG biopsy, treat with steroids. Just know that inclusion body myositis can involve distal disease and doesn't respond to steroids. All right. That was idiopathic inflammatory myopathies. Let's go back and review the other two diseases to kind of wrap this up. Scleroderma is the one you got to know the most about. Recognize that there's a CREST syndrome that involves the hands, face, and esophagus only, and it's treated symptomatically, anti-centromere, versus the diffuse cutaneous systemic sclerosis, which involves the visceral organs, causing interstitial lung disease and renal crisis. If you find renal crisis, the answer is ACE inhibitor. Sjogren's syndrome, dry eyes, dry mouth, parotid swelling, replace what they don't have. Inflammatory idiopathic myopathies, painless proximal muscle weakness, Groton's papules, heliotrope rash, CK EMG biopsy, steroids. That is other connective tissue disorders.